Hello, everyone. Welcome back again in one of the series presentations directed mainly for cardiothoracic surgery residents, where we discuss some important topics regarding our daily work. Today, our presentation will be about an interesting subject, that's the empyema. So, this subject is very old one and has a historical background. It started with Hippocrates 2,400 years ago, and we quote this from one of our textbooks. When empyemas are opened by the cautery or by the knife, and the pus flows pale and white, the patient survives. But if it's mixed with blood, muddy and foul smelling, he will die. This as a signal for the happening of septicemia. Okay, and so for historical arrangement of our subject, it started at the 19th century, where or when the first synthesis was performed, and then at 1875, the oldest closed tube drainage system was invented, and in 1901. Fowler stated that decortication can be performed for patients with non-tubercular empyema. And then all the points were discussed, and all the subject was like being more advanced until we have reached the end of the 20th century, where BATS was introduced into our field. Okay, now to some basic points, starting by definitions. We have the pneumonia, and that this pneumonia can lead to pleural infection, which has many pathways, can be healed, and can lead to a non-complicated parapneumonic effusion, and can lead to complicated parapneumonic effusion or complicated pneumonic effusion, and then can lead to frank empyema. Pleural infection, by definition, in the BTS guidelines, it's bacterial entry and replication in the pleural space. And by definition for the empyema, it's a macroscopic detection of purulent pleural fluid. And this subject or this definition for empyema means that the source might be from pleural infection from pneumonia, it's a lung infection, or can also be from a source of infection other than the lung. Okay, and then we can have a look to the stages, starting with exudative collection, pleural membrane swells and discharge, then exudative fluid, and we have this serous fluid aspirated from the pleural space. The next stage will be the fibropurulent, and we can see heavy fibrin deposits more on the parietal pleura. And the circulation starts here, but the lung can be re-expanded. And then the last stage of organizing stage, where massive ingrowth of fibroblasts occurs and formation of collagen fibers over the parietal and the visceral surfaces, leading to more advanced lung entrapment. And this is the most important question in all our series, which is the approach to the empyema patients. And we have the classic approach, starting by the history, followed by the examination and investigation, reaching to our differential, and finally the management. And history is very important. Starting, we can notice some fever, cough. It can be productive or non-productive, and signs or symptoms of toxicity. Also, drug history is forgotten, and can be very important. This can be the only leading clue for our diagnosis. There's an application. It's called the Nemotox app, and this can help us to identify all the drugs that can cause pleural effusion. And it's very important also to delineate or to recognize the definite cause for any unilateral pleural fluid collection. This diagram or box can show us a differential diagnosis of the pleural effusions, and like you can see, as you can see, very multiple differentials exist. So we have to be very careful approaching those patients. And to the examination, we will confirm the fever. By auscultation, we can hear a decreased air entry at the diseased side, and also we can detect signs of toxicity like the tachycardia and tachypnea, toxic phases, And back again to some historical points from textbooks and to Hippocrates' description for the empyema, saying when applying the ear on the ribs during a certain time, you hear a noise like boiling a wine jar, which suggests the chest contains water and no pus. This signifies the effusion and didn't reach the empyema stage. And moving to investigations, we have chest X-ray, thoracic ultrasound, pleural aspiration, and pH and biochemical analysis, CT chest, PET CT, MRI biopsy. It's arranged from the most non-invasive to the most invasive investigations, and we have to stick to this arrangement. Shouldn't jump to an invasive procedure which can uh, be replaced by a non-invasive one with the same benefit to the patient. So chest X-ray and thoracic ultrasound, chest X-ray is a mandatory initial investigation. However, it's recommended in the BTS guidelines that thoracic ultrasound should be done at initial visits for every patient. And also, they highlighted the importance of the ultrasound mastering for thoracic residents and surgeons. Regarding this point, we have a recent study that's under press and was performed by Ali Zain et al. And it emphasizes the sensitivity of the thoracic ultrasound in detecting the minimal pleural effusion and the importance of thoracic ultrasound being done by dependent thoracic surgery residents and surgeons. So it's a very important point. Moving to the next investigation is which is the pleural aspiration and the biochemical analysis. How we perform this aspiration. All the guidelines now show that the image-guided aspiration should always be used, and no blind aspiration is recommended anymore. Okay, and we aspirate about 25 to 50 milliliters to make sure that this is a suitable amount for good sensitivity. And putting in mind that if the amount is less than this can affect the sensitivity. Syringe should be empty from air and no delay between the aspiration and the analysis. And where can we send this aspiration, or what will we do with this syringe? We will perform pH and biochemical analysis, cytology, and biomarkers. Okay, to sum up this slide, there are three options or results that's possible after the aspiration results comes up. pH is less than 7.2, pH more than 7.4, and pH between 7.21 and 7.39. For pH less than 7.2, this is considered a high risk for complicated pulmonary effusion and is indicated for drainage. If the pH is more than 7.40, it's considered low risk for complicated pulmonary effusion and is indicated for conservative, watchful management and watchful follow-up. And if pH is between 7.20 and 7.40, it's considered intermediate risk for complicated pulmonary effusion. So should put into consideration the general condition of the patient, meaning that toxic patient with high-grade fever favors drainage and can use lactate dehydrogenase cutoff point of more than 900 to favor drainage. So what will we do if the pH analysis is not available? You can use the pleural fluid glucose level, and if it's less than 72 milligram per deciliter, this is an indication for drainage. While all of this, that's because acidosis of the pleural fluid in complicated pulmonary effusion and the low glucose level is attributed to the activity of the leukocytes and acid production. Also, this is an important, actually is very important point. If we suspecting a TB, we should obtain a sample free from blood glucose. I'm sorry, free from blood. Why? This is because Gene Expert, which is an important test in detecting the TB, Gene Expert test can't accept samples containing blood. So this will be a waste for you and waste of time and waste for the patient. So you must make sure that the sample is free from blood. Then we have finished the pH and biochemical analysis, and we will move to the cytology. Infection, including empyema, there is no study. There are no studies regarding the cytology in infection. But for TB, there is ADA or adenosine deaminase, which has a sensitivity of 91% and is being performed in our hospitals. For the malignancy, this is shouldn't be used as a definitive diagnosis, but can be used initially, and this is due to the low sensitivity of the detection of malignancy in the pleural fluid. It has a range of about, generally, let's say 30% of pleural fluid cytology can show a negative results. However, there is a malignancy. So we can use it initially, but it's not as a diagnostic workup. Also for CT chest, we can order CT chest, but it should be ordered in the context of the whole presentation of the patient, so you can make a good use of it. Some rules for the CT: if malignancy is considered, you must order CT chest, abdomen, and pelvis, and also, or if the malignancy is not considered, order CT chest with pleural contrast and the venous face. A very important point also that we want to highlight here in our presentation is that you must explain to the radiologist the purpose of getting this CT, because this will help him to obtain the film that will help you the most. And so you can benefit the patient. So you must order the CT in the context of the patient as a whole case, regarding the history, and also showing the radiologist what you are looking for. PET CT scan is not useful in cases of infection and in cases of infection on top of malignancy, because both will show a positive result or positive intake. And now we have some features which suggest empyema in the CT chest. Lentiform pleural collection, like we can see here, a lentiform collection. Also, you can notice some pleural thickening on the parietal surface, and there is the famous split sign pleura, or split pleura sign. I'm sorry. This is a split pleura sign where you can see the pleura splitting here, and it can appear in CT with contrast. And there is a pregnant lady sign, or inverted D-shaped sign density, and this is due to posterior located pleural effusion. And here it is, the inverted D sign or pregnant lady sign. Like we have said, the PET CT is not recommended in presence of infection. Also, the biopsy, we have general rules. No blind biopsy should be done ever, and no difference. For the biopsy, we can obtain biopsy using image guided or thoracoscopic guided, and thoracoscopic guidance can be surgical or medical. No difference between biopsy obtained by medical or surgical thoracoscopes, the same results or same sensitivity, and definite diagnosis and diagnostic yield higher with thoracoscopic biopsy rather than the image guided, so as a high sensitivity. Regarding the treatment, there are some principles for the management, which include appropriate drainage, control of the source using suitable antibiotics, good nutrition, and respiratory care. And all of these principles should be in the same line together simultaneously. Okay. Drainage, we have closed tube drainage, and also we have surgical drainage. For the closed tube drainage, it's the initial drainage in most of cases with frank empyema. Also, it's indicated if the pleural fluid pH is less than 7.20, and if it's an accessible site, peripheral, and if the patient is unfit for surgery. Surgical drainage using BATS or can be done using open thoracotomy, and BATS drainage is recommended over the open thoracotomy. It's better osmosis and with less hospital stay, less repeated thoracocentesis, and is indicated as a first line treatment in loculated empyema, not accessible to intercostal tube drainage. Here is a diagram of the first module for the closed tube system, and this is our current underwater seal drainage system. I think you can see how much it's the same principle. And then more advanced dry drainage system has been introduced into the market. This is the atrium drainage system, and this is the Synabi drainage system. And then the most advanced is the digital drainage system. One of them is Atmos, and it depends on digitalized drainage under continuous pressure, with many features that help you control the condition of your patients. This is the VATS theater setup regarding the tower, the monitor, and the light source. This is where the surgeon stands in front of the monitor, and the assistant or the cameraman can help the surgeon. This is a wound scar of after VATS surgery that's about 2 finger width or width, I'm sorry, 2 finger width, and this is a scar left after the classic open thoracotomy. Guidance for antibiotic use. This is a guide that you can use. However, I would like or I would recommend that you follow the local policy guidelines according to the clinical pharmacy and the policy in your situation institution. And lastly, there is a treatment of the chronic empyema, which will have a separate presentation due to more advanced details. This is there are some references that you can use, and I have used these references to make my presentation. This appears on thoracic surgery and the BTS guidelines for pleural diseases. And this is the end of our presentation. I hope that this can be conclusive and can be helpful for all our residents. These are very concise and important principles that can help you through your residency and should never be neglected, will help you to get the best results for you and for your patients. I wish you all a good residency period and wish you